is one of 3 groups that are licensed or sponsored by the state to provide education to the people in the marijuana stores that will give you medical advice or direction. I'd like to have Dr. Felice come up and tell you all about it.
Good morning. Thank you all for being here so early in the morning. My name is Dr. Jake Felice. I am a naturopath up in Seattle, Washington. And I'm really excited to be here today to discuss with you about just the very scratching the surface of medical marijuana, or cannabis as I frequently like to call it. We will have some time for Q&A at the end. So without further ado, I'm just going to go ahead and get started. He had mentioned the educational piece, and he had used the word, we're teaching folks how to give medical advice. That's actually not entirely correct. We're actually teaching them how not to give medical advice, but yet still be able to field questions and help people. It's quite a confusing thing for a lot of folks. I'd be happy to take questions about that. One of the reasons I'm here, it was my experience as a hospice volunteer before going to medical school, and I had the unique and wonderful opportunity to do my training in Santa Fe with Joan Halifax, which was just a wonderful experience for me. So why is cannabis important, at least from my perspective? I would say that the broad effectiveness of cannabis is one of its best attributes, and I'm going to discuss a little bit about that today. But what is really amazing about cannabis is not necessarily its effectiveness. For pain, for example, may be moderately effective for pain, but its toxicity is extremely low toxicity. And that, I think, is one of its major benefits, especially compared with many of the alternatives for pain, for example. Medical marijuana does not need to be smoked, and patients frequently do not need to get a head high in order to experience relief from medical cannabis. In all of the peer-reviewed medical literature in any language, there's not a single case report of an overdose death from marijuana. The LD50 lethal dose of marijuana for inhalation, smoking 15 pounds in 15 minutes is a lethal dose. And what's interesting about that is what is killing the laboratory animals in these experiences are not the cannabinoid molecules, but rather the carbon monoxide. Orally, the amount of marijuana that is required to cause death through the digestive tract would almost certainly kill you if it hit you on the head. It's well over 100 pounds. But the real question is, I think for some folks in the room might even be, is cannabis effective? But I'm going to phrase the question, why is cannabis effective? And to answer this, we need to really understand a little bit about plants and how botanical drugs differ from single molecule drugs. Many of you are sure, I'm sure, aware that much of the current pharmacopoeia, the modern pharmacopoeia, has a lot of the origins in plants. And in hospice care or palliative care, there's a lot of awareness about opiates and the endogenous opiate system that we have. We also have an endogenous cannabinoid system. I'll frequently refer to that as the ECS, or endocannabinoid system. It is a 600 million year old receptor system. And it is a naturally harm reduction system. What happened about 600 million years ago, single-celled organisms started getting together to form multi-celled organisms. And the advantages of having a body in the primordial soup, there are a lot of advantages of having a body, but also disadvantages of having a body. And the care of, the evolutionary care of the body was part of the problem that the organism solved as they moved through time. One of the key features of it is protection from lack of oxygen. We see this now in animal studies with rodents. There are now studies showing that myocardial infarction size 60% smaller in the cannabinoid group than the control group, again in an animal model. Stroke infarct sizes are much smaller in animal models, and glutamate toxicity is another one of the benefits, protection from glutamate toxicity. There are attributes of the digestive system. All functioning parts of the digestive system require endocannabinoids for functioning, propulsion, secretion. If you consider after fertilization of the egg, blastocyst implantation into the endometrial wall requires the endocannabinoid system. If that's blocked, no fertilization occurs. And we can block the cannabinoid receptors in newborn mice, the suckling mice, and, with rimonabant. It's a pharmaceutical drug that blocks the ECS. And those mice will actually stop suckling and die from lack of nutrition because they don't have a hunger urge when the endocannabinoid system is blocked. This system also helps with physical effects of trauma, wound healing, tissue repair, and age-related degeneration. The receptor system is 600 million years old. The plant's about 200 million years old. And there is a long history in plant physiology of plants developing molecules that fit into physiologic systems. Caffeine is a good example of that I like to use in my morning talks. The leaves of the coffee tree prevent competing vegetation from growing. So the caffeine in the leaves of the trees drops to the ground and acts as kind of a prevention from other plants growing. The coffee tree will also put slight amounts of caffeine into the flowers, and this attracts insects. Low concentrations of caffeine in the flowers attracts insects, and why do you think that might be? Well, because insects like caffeine too, a lot of them. And also what's interesting is that in the coffee beans, the beans have very high concentrations of caffeine, and that actually acts as an insect repellent. So the plant is using the same molecule to have two different effects. Chocolate is another, from the cacao plant, is another caffeine-producing plant. These two plants have, over evolutionary time, created the same molecule from different biological precursors and different metabolic pathways. So there has been this evolutionary push for this, if you use the lock and key analogy of receptors, for plants developing molecules that fit into receptors of other organisms. The ECS is the most dense receptor system in the entire human nervous system. There are more cannabinoid receptors than there are opioid receptors, than there are nicotinic receptors, acetylcholine receptors, I believe that biology is inherently stingy in terms of what it does. We don't usually have organisms making a bunch of molecules that don't have a purpose. And what it is appearing now is that the endocannabinoid system is managing a massive amount of information. It's involved with every physiological system and pacemaker cells that we have studied to date. And in a nutshell, what is the ECS composed of? It's composed of the endogenous molecules of our body that work on these systems, kind of like endorphins. One is called anandamide and the other is 2-AG, the degradative enzymes, and the receptor system. So that's just a kind of a brief intro to that, and I'd be happy to take some questions on that later. The other thing that I want to really bring to the group's attention today, this is a white paper. This is a white paper put out by the FDA. Guidance for industry. If there's anyone in the marijuana industry, you should definitely look at this. Guidance for industry on botanical drug drug products. So I hear a lot of calls for established research standards, and I think that it's very important that we understand that botanical drugs have inherent issues with the study that are very different than single molecule drugs. Single molecule drugs have a lot of benefits, especially when it comes to study design. Does anyone have any idea why that might be?
Because they're single molecules.
Because they're single molecules. I can buy Tylenol here in Olympia. My mom can buy Tylenol in Florida. We're getting the same thing. There are more kinds of cannabis than there are types of dogs. If you envision a standard dog and think about, let's start testing what dogs can do, not all dogs can pull sleds, not all dogs can swim, not all dogs can sit on your lap. So when we study cannabis, we need to be very aware of the differences, and that is part of the research problem with it. From the white paper from the FDA, I'm just going to read a couple quotes here. Because of the unique nature of botanicals, the FDA finds it appropriate to apply regulatory policies that differ from those applied to synthetic, semi-synthetic, or otherwise highly purified chemical drugs. And this is where I think, for me as a naturopath, and I'd be happy to have a little discussion on this today, the FDA is saying non-clinical data may be appropriate to help establish safe doses and to determine ways to better monitor patient potential toxicities in humans. So I'm not saying let's not have the clinical data, but what the FDA is saying is for a traditional botanical product, non-clinical data is appropriate to kind of have us gauge safety. In terms of studies, cannabis safety has been very, very well studied. It's one of the few things that you can, up until very recently, we've been able to study on the federal level through NIDA. Cannabis toxicities are very well looked at. In fact, if you look in terms of peer-reviewed publication of plants, there might only be one plant in the entire biosphere that has more clinical studies than cannabis, and that would be garlic. So that if we're using the bar of the wrong research for what might be possible clinically, practically maybe one plant in the biosphere might fit into that. Now that's a bit of a misnomer. There are cannabis-based drugs in the pipeline now, Schedule III drugs. There's a drug by GW Pharmaceuticals called Sativex. It's an approved pharmaceutical in Germany and many other places. So there are ways to study cannabis very effectively, but they're not the same that we use for single molecule drugs. I want to just also, so room for questions on that. Moving just into the clinical piece, high-risk populations. There are several high-risk populations for cannabis, some of which I would consider absolute contraindications, pregnant and nursing mothers. Relative contraindication for children and youth under the age of 25. We know that the nervous system develops all the way up and through to the 25th year, so just because you're 18 and making an adult decision legally does not mean that the nervous system is fully matured, and there is some evidence that cannabis can interfere with that, and I'll say the THC in cannabis. Patients with psychiatric illness there needs to be caution used. There needs the recommending physician needs to be aware of the issues. Cannabis can be very good for certain folks with psychiatric illness, and it can be very bad for others. And the last major group would probably be very important for this particular audience: immune-compromised patients and patients on immunosuppressive medication. This is a theoretical interaction. We have not actually seen this clinically yet a lot, but I think that it's something that's very important to be aware of. And side effects. The Sativex studies, which is it's now in phase 3 in the US, but there are some really good studies from Sativex show that The side effects from cannabis are increased dramatically as you increase the level of THC. So the higher the level of THC, the higher the risk of adverse events. So clinically speaking, we want to utilize the least amount of THC possible, which is the psychoactive ingredient, in order to maintain a good clinical effect and minimize side effects. Common side effects are dysphoria, dry mouth, chills. There are short-term memory issues with cannabis. The studies show that they do go away when use is discontinued. Anxiety and irritability are some of the common ones, and for smoke inhalation comes with another series of issues: chronic cough, bronchitis, laryngitis, things you would expect from someone inhaling an irritant. So really two major places for the side effects coming from the molecule THC, which is the psychoactive molecule, and then also from the smoke. Patients do experience withdrawal symptoms if they have been regular heavy users, but they're not severe. Certainly I think less severe than coffee or caffeine withdrawal, for example, but insomnia is very, very common. I would say almost universal in folks who are utilizing cannabis. It's very effective to help patients with sleep, but if they use it over time and decide to take it away, that's a very common thing. Restless leg type syndromes, night sweats, and cravings. So that's the kind of the downside. But the cannabis molecule makes over 70 cannabinoid molecules, which are unique to cannabis itself. We're going to talk about THC and one of those other ones today. Any idea what the cannabis plant uses THC for? It's in the form of a THC acid, and it uses it to repel insects. There is another molecule called CBD, cannabidiol. Has anyone heard of that? Has anyone not? Okay, good. That's excellent, excellent. CBD, they discovered when hemp growers would grow hemp in and around irrigation ponds, all the fish would die. And that turns out was because the rainwater was running into the ponds and killing all the vegetation in the ponds, because the cannabis plant is trying to compete with other forms of vegetation, and the fish died. I think that the area where there's some of the best research is in neuropathic pain, but how patients handle neuropathic pain, muscle spasms, and itching are very similar in terms of what we do clinically. We like to utilize a relatively low THC, high CBD product, or something close to a 1-to-1 ratio, and there's a lot of range for patients to be able to choose. If we're talking about pain, and I think that you guys were looking for some practical advice to take back to folks who might be interested, topical cannabis is a very, very good adjunct for pain. Similar to the opiate system, we have receptors in the brain and the spinal cord and also in the periphery, and we get a synergistic action when we apply cannabis to the periphery, say for example for peripheral pain as well as centrally. And I think that topicals are one of the best ways for patients to get a little bit of relief. My patients typically and very consistently report reductions of about 2 out of 10 on the pain scale from a topical. Not a lot, but it can really help. It's very good for arthritis of the hands. It's one of the most profound ways that patients can see it work, because you can literally see range of motion return in about 20 minutes or so. Not return, but improve. Topicals do need to have THC for their maximum effectiveness. Many of the products in the Washington market are very low THC, but the studies are showing that high THC is better. But because of the way cannabis is metabolized topically, patients do not get a head high when using topical applications of cannabis. For pain also, we do like to use, for night pain, a lot of the times oral dosing. Oral versus inhalation method or oral mucosal absorption, as you're probably aware, will directly hit the bloodstream. When we eat cannabis, the cannabis is processed through our digestive system. The molecules go to the liver for first pass metabolism. The 11th carbon is hydroxylated. That keeps it in the water compartment a lot longer, and that means a longer duration of activity. It clears the plasma more slowly, so patients typically get a longer response. Usually for a topical, you're getting about maybe 2 to 3 hours. For an inhalation, maybe 2 to 6 hours, and for edibles, patients can get up to 12 hours of relief depending on the dose. Nausea and vomiting. Cannabis does have some studies showing it's effective for nausea and vomiting. The current single molecule pharmacopoeia is superior in many ways to cannabis for nausea, but in about 30% of the patients it's not effective for nausea, and for those patients who are not getting relief, sometimes the cannabis can be a godsend. If patients are vomiting and can't keep their nausea medications down, they can utilize an inhalation method, which is usually, if it's going to work, is usually very rapid, within minutes, providing relief. And when a patient utilizes cannabis for nausea and vomiting, they also have the potential, if their side effects are minimized, to be able to enjoy some of the other benefits of cannabis, such as potential pain relief, muscle spasm relief, even all of the conventional meds that I'm aware of for nausea don't actually also help with appetite or prevent cachexia. And cannabis will also help, mildly help with weight gain some of the time. Cannabis is almost universally effective for sleep, I've found. The dose is what is difficult, and the side effects can be very difficult to manage cannabis for sleep, usually because there is a lethargy if the dosing isn't right with an oral dose. So there is a pretty narrow sweet spot. I'll frequently tell patients who love to hear this that if you haven't had sleep in a long time and you find yourself hitting the snooze button a lot in the morning, that probably means that your dose was too high. The ideal dose of cannabis, patients should not be feeling groggy or hungover in the morning. PTSD, there is some new and emerging research. It's very exciting. Very small human studies now, but nearly 70% of night terrors disappear on night one. So patients with night terrors get very good relief. For this particular piece, the THC is important. We are not seeing, because the psychoactivity is a little bit important. Now, this is something that's going on when folks are sleeping, but what we think that the cannabis is doing is it's helping the nervous system to extinguish and let go of painful memories. They are now carrying cannabis in ambulances in Israel, and what they have found is that for the traumatic event, cannabis is best administered within 24 hours. The nervous system tends not to fixate on the trauma as much when the cannabis is administered very quickly. And we do see in medical cannabis states decreases in veteran suicides. And we also see in medical cannabis states the Journal of the American Medical Association, I can't remember if it's that or the New England Journal of Medicine, about a year ago came out with a study in licensed medical cannabis states. There's a correlation with 25% fewer opiate prescription overdose deaths in cannabis states. Cannabis does positively interact with opiates. The reason for that is that even though we have even though every single cell in our nervous system has cannabis receptors, the smallest numbers of those receptors are in the brainstem, heart and breathing centers. So no matter how much of the cannabinoids we give, we're not seeing respiratory arrest, we're not seeing issues with the heart stopping. So, and I think also, especially in the hospice realm, just folks who are maybe not necessarily having anything diagnosably clinical, but just not comfortable in their body or having a difficult day in their body, there can be an ease of rest and comfort that folks experience with medical cannabis that is subjectively very pleasant for them. And I know that there's a lot that I'd like to talk about, but I think what I'd like to do is just open it up to Q&A, and I'd love to hear your questions and we could have a little discussion.
Define neuropathic pain for those who don't understand.
Neuropathic pain is pain that is caused by nerves rather than inflammation. So say, for example, if a tumor is pressing on a nerve, that can be a neuropathic pain. It could also be caused by medications or certain disease states like diabetes where there's an irritation in the nerve. Neuropathic pain is very difficult to treat. Opiates do not always do a very good job with neuropathic pain. And the other thing with cannabis and opiates is that the cannabis actually potentiates the action of opiates. So patients who have developed a tolerance with the opiates, cannabis can reduce that tolerance. And also, interestingly enough, for opiate withdrawal, cannabis helps with symptoms of opiate withdrawal as well. So cannabis helps the opiates work better, and it helps the patients use less of them. Yes, ma'am.
You mentioned Israel. What's the delivery type in Israel?
I believe they're doing an oral mucosal spray, but I would have to check on that. Yes. Yes, ma'am.
What about its use? Has it been tested on tremors?
Not so good with tremors as it is with seizures. I've done a fair bit of work with Parkinson's patients. It's pretty frustrating a lot of the time. Sometimes you hit a sweet spot. Sometimes it works very well for certain patients. I have a patient, for example, we talk about CBD and THC. I have a patient who it's absolutely ineffective at a 16 to 1, and at a 20 to 1, they're getting good relief. We don't know why that is. Could it be something other than the THC and the CBD in the plant? We know that the plants make terpene molecules. Other plants make terpene molecules, and terpene molecules are effective at very low concentrations, like 5 nanograms per ml. So super whisper doses of terpenes can cause that. So we don't know why, but it can be very specific. Like, so just like, for example, I want a big dog that doesn't have a lot of energy, can sleep in a little space, and can go out and jump into the cold ocean and haul in lobster nets. That's a Newfoundland, that's a Newfie, right? So you can get very specific with cannabis as well, but again, this requires a lot of time to do that. Yes, sir.
What was it, 2 weeks ago that the government really put a downer on?
Well, that's correct, but there is a silver lining in that. So that they did just revisit cannabis's Schedule I status, and they said, yep, it's still Schedule I, huge risk of harm, no potential medical benefit. But what they did do is prior to that ruling, there was a federal moratorium on research cannabis, so that if you were a researcher, you couldn't get marijuana if you had federal fundings except through NIDA, and now they have released that. So there was one thing that they did, which I think is actually a big thing, but in terms of the Schedule I status, that makes it difficult for everybody. Yes, ma'am.
You were talking about higher THC with CBD, but it was my understanding that if the THC is 20%, or more, it burns off the terpenes and the CBD. It doesn't really they don't come along with
The terpenes volatilize. The terpenes what are terpenes? Terpenes are cyclical molecules that the plant makes, and a lot of them have flavors. So citrus is a terpene. Pinene, which gives pine its smell, is a terpene. That is age, heat, and storage dependent. So you can lose terpenes when you cook cannabis. If you're cooking cannabis at home and you smell that dankness in the air, that's patient's medicine in the air. So I tell patients you want to minimize that. Yes, terpenes certainly can be lost, and the same cannabis today will be different cannabis in 6 weeks. As far as terpenes go, some of the major terpenes that affect marijuana for sleep induction, you can have a 10% THC marijuana that induces sleep. You can have a 10% THC marijuana that will keep a patient up all night. That would depend on the terpene profile. A lavender terpene called linalool is very sleep inducing. Also, mangoes make a terpene called myrcene. So myrcene and linalool will cause this, what we call a couch lock effect. Some patients really like the couch lock effect, and a patient who is kind of restless and irritable in their body, that couch lock effect kind of provides a sense of relaxation, comes from the terpene molecule. So terpenes are extremely important. So just all these things, and how can you study one particular type of cannabis? It poses a lot of challenge.
But you're talking about difference. You're talking one
Yep.
was about a
So
and one was about an
yep. Now, to my awareness, there's the percentage of THC does not, to my knowledge, affect terpene delivery.
Okay.
Yes, ma'am, in the back. You've been waiting. Thank you.
Have you heard about some success or had it yourself with treating patients with dementia? So can you speak to that?
I have not. I think dementia it's difficult to peg because sometimes it's one step forward, 2 steps back, or vice versa. There's so many factors. There are some very good indications now in the science that cannabis is very protective, certain types, especially CBD types, for neurodegenerative disorders. Some of the best studies are the MS studies, although there are some Huntington studies that are pretty darn good. But the MS studies, we had over 100 MS studies on cannabis in 1996. That was before, that was a long time ago. I don't know how many there are now. And we do believe now in MS that there is reason to look at it further, that the cannabinoids, because of their influence on the immune system, are positively modulating the disease process, not just affecting symptoms. I see this in my rheumatoid arthritis patients as well. Gentleman in the back.
Now, you mentioned cream for pain topical. What level of THC would you recommend?
I like a 1-to-1, and I like the THC at a very, very high concentration, and CBD is also important. The studies are very clear and they're limited, mostly animal studies. We do have one human study with a post-herpetic neuralgia, no, it's a trigeminal neuralgia, I'm sorry. The concentration of it's a dose-dependent thing, and also that brings up the idea of what about if we just use a single molecule as opposed to the whole plant? So we use CBD, for example. Again, in an animal model, what happens when you just use the single molecule is you get a bell-shaped response curve, which means the therapeutic window is very narrow. But if you use a predominantly CBD yet whole plant-derived, it changes the entire dose response curve and makes it linear. So that means that there is a dose-dependent result, at least for that target molecule. They were looking at an inflammatory cytokine with that one. Yes, ma'am, in the back.
You touched on seizures. Could you
Yes.
expand on that a little bit?
Yes, seizures are getting a lot of press, especially with children in seizures, Dravet syndrome in seizures. I have clinically seen some pretty remarkable results with seizures. Had a patient who was seizing upwards of 200-300 times a day. with the proper cannabis dosage initially. He actually went 3 days once without a seizure and was averaging 0 to 10 for a long period of time. But it can be very effective. I would not want it to use it as a standalone. But the other thing is, not only are we seeing it reducing seizure and intensity, severity, maybe even duration, but what's also very interesting about cannabis and seizures is that it's very protective against glutamate toxicity, which when the nerves get overexcited, they release an amino acid that can, in high concentrations, be toxic to the nerves. Cannabis is very protective against glutamate toxicity. So I think it's a good option. I always am a little... I'm never confident with seizures as I am with pain or as I am with sleep, but I have seen some pretty amazing things. It certainly doesn't work for everybody. I would not want to take that hope away from anyone, and I would say that I think that the thing that most clinicians are doing wrong is they're still just not spending enough time with patients doing the necessary educating. So it is something that the patient would need to be followed. Yes, ma'am.
I wanted to say that I started using a stick called Remedy.
The Remedy pain stick from Cannabis Basics, high CBD, high THC, and terpene rich.
I have neuralgia, like a occipital neuralgia, which is sort of like a shooting pain from your neck to over your head, it's like a burning. I've had it for years, and I've had all kinds of, treatment, nothing helped. And he said, let me try this new thing. He didn't say what it was. And he put it on, and it immediately went away. And I thought, well, just, it doesn't happen all the time. So I've been using it every day, in the morning, just once a day, and I don't have it at all.
Do you mind if I ask you a question about that? How high did you get? How euphoria? Head high? 0. That's how, yes. That's why I asked that. That's why I asked that. I'm sorry to embarrass you. Nothing necessarily is wrong with the high if you want it, but some patients don't want that. Topicals. That would be my pearl for today for you folks, is utilize the topicals or recommend the topicals. Well, I think I'm seeing 1 minute or one question. Over here, yes.
I'm curious if you would ever recommend it as a preventative measure.
As a preventative measure, absolutely. For pain, anybody a big, probably not anybody a big Ultimate Fighter fighting fan? Nate Diaz, anybody were you for Nate or were you not for Nate? Nate was shown in the post-fight press conference using a CBD pen. Very good for traumatic brain injury and also as a preventative. Fighters, I have had a number of MMA fighters. They are almost universally before sparring. I don't know about before competing, but I suspect utilizing topicals. Absolutely. Mm-hmm. One more question, okay, yes.
Yeah, we help patients with end-of-life care, often cancer, terminal cancer. I had one client that used cannabis, and it seemed to really help her. And she would say, go get my marijuana. And she would take a little bite, sometimes she would take a big bite. Does the dose, the size, how do we help with it? So second clinical pearl. One of the biggest ways a new patient can get into a lot of trouble fast, not biochemical trouble, but mental and emotional trouble, is by having too much of an edible. And the oral delivery method is not reliable because part of the absorption has to deal with transit time. So if the transit time through the digestive tract is different, the absorption rate is going to be different. I usually peg, for my patients, I give them an exact recommended amount of THC where I want them to start, and then I tell them to go up slowly, and I also let them know that if they do take more than they had hoped for, that they're probably never going to want to do that again. It can be very uncomfortable for patients. So it requires an experienced patient to be able to just very quickly dose themselves. I would be very cautious for a cannabis-naive patient to just kind of break off an amount and take it. That you can get pre-measured and scored medicine now.
that's been laboratory tested. That was my last question. I wish we could answer 50 more. I would love to come back and chat with you guys. Thank you so much for your time. You can reach us at Medical Marijuana 411 on Facebook if you like, and also I'm drjakefelice.com and also on Facebook. Thank you so much for having us. I really appreciate it.